For decades, reconstructive dentistry operated on a strict timeline. The original brain-mark protocol required a newly placed implant to sit in a completely load-free environment. You had to wait through months of healing to guarantee the bone had fully fused to metal before attaching a tooth. Today's clinical landscape looks very different in modern dentistry. Patients expect immediate results, less surgical trauma, and uninterrupted aesthetics. They do not want to walk out of the clinic with a missing tooth. To meet that demand, the International Team for Implantology established a standardized matrix for the treatment. The highest tier of this is the Type 1A protocol, the immediate placement followed by the immediate functional loading, where a prosthesis is attached within 48 to 72 hours of surgery. Moving from a submerged dormant implant to an active immediate load introduces a massive biomechanical risk to the freshly cut bone implant interface. Success in any implant procedure lies entirely on osseointegration. Osteoblasts must form a direct mineralized connection right against the titanium surface to lock it into the jaw. If that delicate connection is disrupted, the body defaults to a different healing pathway, fibrous encapsulation. Instead of bone forming cells taking hold, aggressive fibroblasts multiply quickly and coat the implant, physically blocking the bone cells from attaching. This type of biological failure is highly deceptive. It is completely asymptomatic during the initial healing phase. The clinician and patient would not know there is a problem until the implant begins to shift under pressure of normal chewing. Immediate loading pits the patient's demand for instant function against this microscopic threshold for biological failure. This graph tracks the lifespan of an implant's mechanical grip in the jaw. At the exact moment of insertion, the stability is purely mechanical. We call this primary stability. It comes entirely from physical friction between the implant threads and surrounding osteotomy walls. Over the next few weeks, that friction starts to fail. Osteoclasts arrive to clean up the surgical site, and as they do, they actively resorb the bone immediately adjacent to the titanium. The primary mechanical hold a pneumatis. Simultaneously, secondary stability begins. The body gradually forms new woven bone and denser lamellar bone that physically grows into the surface of the implant. The primary mechanical grip is failing and the secondary biological grip is not yet robust. This trough is known as the stability dip. During this phase, any biting force applied to the tooth can cause implant to shift. If the micromotion exceeds 150 microns, the biological transition breaks down and fibroblasts take over. The entire engineering objective of Type 1A protocol is to maintain total stability above that specific microscopic threshold until the new bone is completely formed. Predicting if an implant will survive the stability dip requires the objective matrix long before surgery begins, starting with a precise analysis of bone density. Immediate loading is most predictable in mesh type 1, 2, or 3 bone. Clinicians verify this pre-operatively by quantifying the jaw's density using Hounsfield units extracted from CT scan. A score above 70 proves the site is an ideal candidate for immediate loading. If that score drops below 60 in the weeks following placement, the biological transition is failing. Relying on manual feel is insufficient. Meeting these exact torque and stability parameters inside complex human anatomy requires stripping all guesswork out of the surgical workflow. Consider a highly complex clinical scenario. A patient presents with an unrestorable maxillary premolar that needs to be extracted and replaced on the exact same day. A standard evaluation reveals a severe anatomical constraint. There is an impacted adjacent tooth follicle resting directly beneath the target extraction site. Attempting a pre-drill sequence here risks severe structural damage. The modern digital workflow solves this by fusing two specific data sets. The clinical team takes 3D volumetric bone data from a cone beam scan and merges it perfectly with a high surface architecture scan of the patient's gums and existing teeth. This creates a virtual environment for top-down planning. The team designs the final prosthetic tooth first to establish an ideal emergence profile, then software plots a straight line trajectory backward from the center of virtual tooth down into the bone. This restorative driven path guarantees the implant will support the new crown properly while maintaining a rigid 2 mm safety from the margin of the impacted tooth follicle below. The data merging takes implant placement out of the realm of the bone driven compromise and turns it into a highly precise. Translating that scheme into physical reality starts with the extraction. The surgeon must remove the failing tooth atraumatically to preserve the incredibly thin, delicate facial bone plate at the front of the socket. Surgeons often utilize a flapless approach. By avoiding wide incisions, they maintain the integrity of the periosteal membrane and its critical blood supply, which prevents the surrounding bone from starving and resorbing. Inside the empty socket, the implant is intentionally positioned towards the thicker palatal or lingual wall. This purposefully leaves a physical space between the titanium and the fragile facial bone. This space requires immediate biological management. Any gap larger than 2 millimeters between the implant body and buccal plate is a severe risk area for tissue collapse. Clinicians fill this void with a slow resorbing bone substitute. This graft material physically holds the shape of the socket, preventing the wall from caving in during the natural remodeling phase. These surgical micro decisions, staying flapless and actively grafting their gap, act as an essential physical defense against bone resorption. They ensure the aesthetic architecture of gum lines survives the trauma of extraction. The final physical step of the Type A protocol is attaching a provisional prosthesis within 48 hours of surgery. Historically, dentists modified temporary prosthesis directly in patient's mouth. But heavy chair side drilling, manual adjustments, acrylic curing apply unpredictable torque and violent vibrations directly to the freshly placed implant picture. The digital workflow eliminates this hazard by relying on the precise top-down virtual plan. A lab fabricates a customized PMMA provisional crown or a supplemented framework before the patient ever arrives. This prefabricated tooth features a highly specific under-contoured emergence profile. It is mathematically designed to hold the surrounding marginal tissues in place without applying blood-restricting ischemic pressure. Delivering a perfectly passive premolar tooth removes the need for intense chair-side manipulation. It acts as a rigid physical shield that fiercely guards the fragile mechanical stability achieved in the bone. The immediate loading protocol presents a difficult biological paradox. Clinicians are intentionally applying load to the implant at the exact moment osteoclastic activity is actively stripping away its mechanical grip in the jaw. Navigating that transition successfully demands a rigid synchronization of biological timing and mechanical precision. The mathematical boundaries are absolute. The implant stability quotient must stay above 70 and functional micromotion must be strictly below 150 microns. Hitting those numbers predictably is achieved through the exact integration of the cone beam imaging, precise intraoral scanning, guided surgical placement, and passive prefabricated prosthetics. By acknowledging these biological limitations and executing the procedure through a precise digital architecture, Type 1A protocol moves immediately implant loading out of realm of biomechanical gambling and turns it into a highly predictable engineered reality.